Hello and warm welcome to another webinar co-organized by ANT Neuro. My name is Farnoosh, I'm the Head of Education at ANT and glad to be moderating today's session on triage of stroke patients in the ambulance with EEG. Our presenter today is Dr. Wouter, who is a technical physician in the Department of Neurology and Clinical Neurophysiology at Amsterdam UMC. He obtained his PhD in the field of MRI research and has got extensive clinical experience in nerve and brain stimulation and EEG. In 2018, Dr. Potters and Dr. Coutinho won the Amsterdam Science and Innovation Award for their idea of a stroke triage using EEG. After the scientific part, there will be a short practical session in which Dr. Antonia Tallon, the Senior Application Specialist at ANT Neuro, will walk you through the setup explained in this webinar, introducing EEG Mini and WaveGuard Touch Dry EEG Cap. As always, there will be a short Q&A session afterwards, and you can send your questions already in the questions chat box. In the meantime, there will be some poll questions for you to answer during the presentation to keep the session more interactive. So let's start, Dr. Potters. Thanks a lot for accepting our invitation to do this webinar. The stage is yours, and we are looking forward. Thank you.
Yeah, thanks a lot for the introduction, and also thank you for inviting me to give this presentation. And for all the audience out there, thank you for taking the time to actually listen to this webinar. I'm going to talk about the triage of stroke patients in the ambulance with EEG. Before I do that, I still wanted to give a short introduction of where I come from. I come from the Netherlands, from Amsterdam, and the two university hospitals in Amsterdam actually are now cooperating under the name of Amsterdam UMC. So this is quite new for some of you maybe. So we have two locations. So these are two different university hospitals. University medical centers in Amsterdam, and we cooperate a lot nowadays. We work with over 15,000 people. We see 350,000 patients a year, and we're of course teaching and training thousands of young people. Well, in Amsterdam UMC, we have a very complex patient care and highly specialized treatment of stroke. We also perform research in the Research Center of Amsterdam Neuroscience, so that's where this project also is coming from. And we, of course, do international cutting-edge stroke research. So I will keep this very short because I was already introduced, but I work in the Department of Neurology and Clinical Neurophysiology, and I do several clinical and research tasks. But before we go on, I would like to know, who are you? So here is a poll question. Are you A, a clinician, B, a researcher, or C, both?
So the poll is ongoing, and we can give this 30 seconds.
Okay, so we wait a short while. I would see myself as a clinician and a researcher, so C, both, because I do clinical care, but I also do research quite a lot on several topics. So I'm really curious to see who you are.
Okay, 83% voted so far, and it seems that 18% of the participants are clinician, 63% are researcher, and 20% both.
Okay, well, so that's means that we have a lot of intelligent people here. We're all researching cutting-edge research, so I hope I can live up to your expectations in this presentation. But before we go on, I also would like to know if you're working with EEG at all, because it gives me some information if I need to tell the basics or not. So it's a very easy yes or no, so it should be quick. And many of you probably work with EEG if you're in the ANT Neuro webinar, but perhaps not all of you. I work with EEG mostly in research, and especially in this context of this project of EEG in the ambulance, but I will talk more about it soon. So just wait a little bit before the results come in. It's about 50-50.
Those are very interesting. Yeah, 53% yes 47% no. So that's a very mixed kind of audience.
Yeah, so there's something to learn for everybody, I think. So let's quickly continue to the actual contents of this presentation. I would like to mention that I'm giving this presentation, but of course this entire project is a joint effort with mostly my co-PI Jonathan Coutinho. Together we set up this project, but also Henk Marquering from the Biomedical Engineering Department and our two PhD students, Laura van Menen and also Marita van Sticht, contribute a lot to this project and also to this presentation in the form of slides. If you would like to read more details about our project, you can just go to this link where we actually published our first draft of our research protocol, which we're currently using, and I will also be presenting in this presentation. But
sorry, Wouter, I'm sorry for the interruption. It seems that your slides are freezing. So could you please reshare your slides?
I can definitely do that. I think it might be due to the poll that we had. I will reshare the slides. Can you see my slides again?
Yes, we can see that, and yeah, now it's perfect.
That's perfect. So before we can talk about stroke, we first need to know something about how the brain actually gets its oxygen in its blood. There's actually two ways in which blood is pumped to the brain. One are the internal carotid arteries, which you can see on the left side. You see a small circle of vessels there. That's the circle of Willis. And in the anterior part of the circle of Willis, there are two common carotid arteries, which split in an external and an internal carotid artery. And this internal carotid artery actually feeds the largest part of the brain, and then mostly through the middle cerebral artery, which you can see on the left and the right side. And if you then look on the right picture, you can see the yellow area. That's actually the area that is fed by the MCA, or the middle cerebral artery. So that's quite a large portion. Of course, this is only one cross section, but it is a very large portion. And then also a small part of the brain is fed by the posterior circulation. But for the sake of this presentation, that's less interesting because we're especially interested in problems with this internal carotid artery or middle cerebral artery. And what are then these problems? Well, that problem we're going to talk about is ischemic stroke. And the result of ischemic stroke is a poor or no blood flow to more distal brain areas. There are actually two types of strokes. You can have a ischemic stroke, which actually a blood vessel is blocked. And you can also have a hemorrhagic stroke, where a blood vessel bleeds and bleeds so much that the blood that is actually intended for the brain goes into this bleeding, so the brain does not get any blood anymore. And today we're focusing on the ischemic stroke. It's also more frequent than the hemorrhagic stroke. And more importantly, it's also very well treatable. Ischemic stroke can be treated in two ways, namely with intravenous thrombolysis, where we actually thin the blood, so to say, to actually dissolve the blood clots in the brain. And it works by injecting this medication into the bloodstream. And a second method that can also be used is intra-arterial thrombectomy. You can see that on the second image here. So below the word thrombectomy, you can actually see that you can go into the blood vessel just above your leg with a catheter and just go all the way up until you are at the position where you have a ischemic stroke due to a blood clot there. And then you can use a stent, which you put inside this blood clot to actually capture the blood clot and just pull it out. So you can imagine that if you have a blood clot and you pull it out, you immediately restore the perfusion to the more distal parts of the brain. So this works really well. You can also have a ischemic stroke in one of the more smaller, more distal vessels. And you can also imagine if these vessels get smaller and smaller and smaller, it gets harder and harder and harder to get through these vessels with the catheter to get all these curves. So then it's no longer possible to perform intra-arterial thrombectomy, IAT, or as they also call it, endovascular treatment, EVT. So these are all abbreviations, but it's important to know that for the large vessel occlusions, you can do IAT or EVT and intravenous thrombolysis, and for the smaller blood vessels, that's not an option. Well, and why is it important that we treat these people? Well, because if they just got their ischemic stroke, you have a very small region of tissue that gets zero perfusion, and that's infarcted tissue beyond recovery. We cannot do anything about it. But as you wait longer, this infarct core actually starts to grow, and it gets larger and larger and larger. So you can imagine that if you treat these people, you can actually prevent this infarct core from getting bigger, and you also save more tissue. And sometimes this tissue that still can be saved is called penumbra. So that's the viable cerebral tissue that still gets blood supply by collaterals, but not as much that the tissue can survive for a prolonged period. So it's viable, but if you don't do anything about this disease, then it also will be infarcted tissue. And the cellular mechanisms after stroke, well, there are many mechanisms, and all these mechanisms also take place on a different time scale. And right after you get a stroke, the first thing that happens is you get a bioenergetic failure. And if you then wait a few minutes, you can also get microvascular injury. You can get, if you wait even longer, you can also get post-ischemic inflammation, oxidative stress, and I forgot about the excitotoxicity. So you get all kind of cellular processes that actually cause these cells, these neurons, to actually die or function less. And you can also imagine that that has a different effect on the signals that these cells produce. So they can be functional if you are still in a very early phase, but as you wait longer, they become less and less functional. And if you wait very long, even up to days, you can also get effects where the blood-brain barrier dysfunctions, and you can get all kinds of secondary problems. So it's very important, again, that we treat these patients fast. So really, the one thing that you need to remember from this treatment is really time is brain. So any minute or 5 minutes that you wait, the patient will get out worse than you want them to. And to give you some indication about, I think 15 years ago, this endovascular treatment was not yet readily available everywhere. So that basically meant that all these patients with a stroke just went to a nursing home, and they didn't go home again. And with this treatment, they can actually go home again and go to work again. But we also know with this treatment, because time is brain, that we need to perform it really, really, really fast. So as fast as possible. It's the same as in a myocardial infarct. You just need to treat them right away. So we need to take them to the hospital really fast. And this is the situation in the Netherlands. We actually have 62 hospitals in the Netherlands where they perform intravenous thrombolysis. So they put the medication directly in the bloodstream and you dissolve the blood clots. But you have only 20 hospitals, which is quite a lot because the Netherlands is quite developed in this sense. 20 hospitals where they perform IVT, but also endovascular treatments. And the reason why it's not in all hospitals is, I think, twofold. One, it's expensive, but two, it's also really difficult to have a complete team of doctors, nurses stand by for 24/7 with the proper ER so that you can actually perform this treatment also when this patient arrives with the ambulance. Because usually when the ambulance arrives, people get to the CT scanner, and once they confirmed that it's LVO, a large vessel occlusion, that is actually treatable, they just directly run to the treatment room. So it's all going very, very fast. And everything is aimed to make this period even shorter. So the current situation for a patient is somebody, for example, has a dropping arm or dropping leg, so loss of power, loss slurry speech, and they call the ambulance, they call the paramedics. Well, we have a problem, and the paramedics then think, oh, well, based on these symptoms, we think it's a stroke, so it's a suspected stroke. And what they do is they just go to the patient, pick them up, drive them straight to the closest hospital. And in this closest hospital, they're actually, the first thing they're going to do is a neurological exam and also a CT. And currently the gold standard for detecting these large vessel occlusions is with CT, computed tomography, with or without contrast. There's always discussion about it, but usually they do a non-contrast CT, and sometimes also a contrast CT. Based on that, they state the diagnosis. And if it's then the case that's a large vessel occlusion, then they call the ambulance again, and the ambulance transports these patients to the bigger hospital where they can actually perform the endovascular treatment. So I was wondering, as you might suspect, we don't think that this is maybe the ideal situation. So what do you think would be the ideal situation for suspected stroke patients? Is that question A, we want all of them to bring them to the closest hospital, basically how it is now. Maybe we want to transfer all these treatable patients and non-treatable of all these patients directly to a large hospital where we do both treatments, so they get the best treatment possible as fast as possible. Or do we only want to take these patients that are treatable with IAT to this large hospital? So I'm curious what you all think. So situation A is how it's being done right now. So we wait a little bit for the answers. Okay, so most...
You can see the answers, right, Wouter?
Yeah, I can see the answers. So 67% of the people said that only the LVO strokes need to go to the large IAT hospital. Some of them also think, well, maybe we should take all these patients to the large IAT hospital. And some people think, well, the situation how it is now, where we bring all people to the closed hospital, is actually quite good. Well, A is, of course, for the situation right now, it's perfect. But what we ideally want is actually, please let me know if my slides are not working again, because only 7% of these suspected stroke patients actually have a large vessel occlusion. So, for example, in North Holland, if you get 10,000 patients and you would take all of them to Amsterdam UMC, well, that would be a kind of a burden, because then our emergency department is going to get very angry with the neurologists because they can't handle 10,000 of these patients each year. Not even 5,000 or 4,000. So what we really want in these large hospitals, we want to perform as many endovascular treatments as possible, because that makes it efficient and also more effective, and we can have 24/7 service for these patients. But we don't want all these patients that only need the intravenous thrombolysis. So ideally, what we would like is that we bring all the large vessel occlusion patients to the hospital where they have endovascular treatment. And all the other patients, we want to bring them to the closest hospital. And please note that sometimes these large hospitals are also the closest hospitals. So in that case, just bring them to the closest hospital. And we think that this is the best way for the patients. But what do we gain by that? Well, we actually calculated that, as you can see in the references. And if you directly transfer the patient to these large hospitals, you get a 1 hour decrease in the time to treatment. And what does this then mean on a group level? You get an absolute chance of functional independence. So that means these people can stay at home of plus 15%. So that's quite a lot. So 15 out of 100 patients actually get home. And some patients have such a big stroke that they won't survive, or they will be, well, it's beyond recovery. So you cannot do anything about it, but still it's 1 hour of treatment time delay, and sometimes even more, will get an absolute chance increase of functional independence. Now, what do we need if we want to do this? Well, we think we then need to look inside the ambulance to see, well, what can we do there to actually make sure that we bring these large vessel occlusion patients to the right hospital. There are several methods. For example, in Berlin also there is an ambulance driving around with a CT scanner inside the ambulance. It has a perfect diagnostic accuracy. But you can imagine if you want to roll out this to 100s or 1000s of ambulances, it's way too expensive. And it also requires a lot of training. It's not compact at all. It's basically like a semi truck that needs to drive around with the CT. You have a lot of radiation regulation issues, and it's totally not affordable. So we thought, well, we need something that is good in diagnostic accuracy. It doesn't have to be perfect, but it at least needs to be good to get most of those 7% actually to the right hospital. And there can be a few false positives. That's not too bad, as long as it's not too many. It needs to be fast, because we don't want to delay this ambulance, because a lot of these patients still want to go to this closest hospital as fast as possible. We want it to be applicable with minimal training, because you need to train a lot of paramedics to actually use such a solution. It needs to be compact, because they need to bring it to the living room of the patient, besides the fact that they already have tons of other equipment in their bags. And it needs to be relatively affordable, because only 1 out of 100 patients in the ambulance actually is a suspected stroke patient. So you cannot spend 50,000 euro on a setup in this ambulance, because it's way too expensive, we think. So that's why we came up with EEG as a triage instrument. Jonathan Coutinho actually came up with this, and he came to me and said, well, can we do EEG inside the ambulance to actually triage these patients? But there are a few downsides. You have very long setup sites, because you have to abrase the skin, you have to put on the electrode paste, put on the electrode. Now that requires experienced users, because you need to put it at the right position. But there is also 2 big advantages. You have excellent electrical contact and very good signal quality. But in practice, because we need to be fast, it's not possible. So that's why we came to the dry electrode EEG, where we actually have a lot of advantages, because the dry electrode EEG does not require this electrode paste. You don't need the skin abrasion, and you have quite a quick setup time compared to the wet electrodes. And if you only have to put on your cap, it's quite easy to train users to do that right. But there is also downsides, because the electrical contact, by definition, for a dry electrode, it's lower than for the wet electrode, so you get a lower signal quality. But if you also think, well, maybe the difference between the affected hemisphere and the non-affected hemisphere is very large, we can maybe live with that. So here you can see an example of the electrodes, but after this presentation, there will also be more details about this. And then I have the next question. If you look at this EEG signals, so we see 2 EEG signals, on the left hemisphere 1 electrode, and on the right hemisphere 1 electrode. And for the sake of illustration, we simulated this data, so it's not actually measured in a patient, because we never have a time where actually the stroke occurs, because we always measure after the stroke, of course. Where do you think that the stroke occurs? Is it in the left or is it in the right hemisphere? So in the red line or in the black line? So we wait a little bit for the results. I see in the meantime that it's already 25 minutes past 3. So the poll questions are taking a little bit longer than I expected. So I will speed up a little bit. So I see that most people answered it correctly. So it's indeed the red line, 74% of the people had this correct. And I will now go into detail why this is the case. So what you see is if you have a frequency spectrum, you see that the low frequencies actually increase and the high frequencies actually decrease. So this is typically what you see when you decrease oxygen to these neurons. You get a slowing of waves, so to say. So an increase in low frequencies and a decrease in the high frequencies. And we also know this from carotid endorectomy, where we actually clamp a carotid artery. For the case of surgery, where we do monitoring with EEG, you can see that before clamping, you see on the left that you have a proper cerebral blood flow. And on the right, after you clamp, then you see that there is actually a part of the brain that has a much slower wave, so to say, and also less activity. And then this actually correlates, but I'll go quite quickly because I don't think we have too much time. But you can see on the left side that this is from a paper of Foreman and Klaassen in 2012. You can see that if the blood flow is really low, below 10 milliliter per 100 grams a minute, then you get really suppression of signal. If you get a little bit higher flow, you get increasing slower frequencies. And as the flow goes up, you can see all kind of different processes take place. So the amount of blood that flows to the brain matters a lot. And the more it decreases, the higher the signal changes get. But also with a small decrease in cerebral blood flow, for example, left versus right, you would expect changes in these images. Just to remind you, the frequency bands for people that don't work with EEG a lot, we have the delta frequency, which is at the bottom, which is very low, and then the theta, then the alpha, and then the beta. So the beta is the highest frequency, the delta is the lowest frequency. And what we know from literature, there's quite a lot known in literature in these stroke patients, is that we see an increase in delta activity at the site of the ischemic core, and we see a slowing and attenuation or loss of the alpha and the beta background activity overall. And it can be unilateral, but in some cases it can also be bilateral, because the two halves of the brain, of course, also communicate. So it's not necessarily so, it's often the case, but it's not always the case that only one hemisphere is actually gets a change in its signal. And then this figure by Finnegan from 2016 actually shows this really well, where they have control participants, where they quantified the amount of delta, alpha, theta, and beta. And they also did it in stroke patients, and you can clearly see that you get an increase in this delta for the core. And all this current literature is mostly based on data that's measured more than 12 hours after the onset of the stroke. And there's little patients in stroke patients before 12 hours, and there's actually no data in the acute ambulance setting. So there's a really large gap in literature here, because we know from beforehand that there are processes that take place over time, but these processes also change continuously. So it's really important to get to measure this data in this really, really early phase, so before the emergency department. At least we think it's really important. We'll see if that works out, because of this cellular mechanism that take place over time. So if we measure earlier, we might measure different signal changes. So the primary objective of our study is to determine the diagnostic accuracy of dry electrode EEG for the diagnosis of large vessel occlusions. And secondary to the accuracy, we're of course going to look at specificity, sensitivity, but also really important, because this is really a pilot study. It's a diagnostic pilot study. We're going to look at feasibility, both technical, can we actually measure the difference between LVO and the non-LVO? Can we actually perform the training in these paramedics and for these paramedics, and can they actually get data that is of sufficient quality to analyze? So these are all aspects that are included in this diagnostic pilot study. And before we go on, I want to quickly point out this article by Irani, which was published in 2020, where they actually did a similar thing. So they measured 100 patients in the emergency department, where they looked at 63 acute stroke patients, which was a transient stroke. So a transient stroke means it's gone after a while. It automatically resolves itself. And there were 7 large vessel occlusions in these 100 patients. And they actually looked at different models based on EEG parameters and based on clinical parameters, and those combined. And you can see that they get the AUC of maximum of 88%. Of course, this is only 88, sorry, AUC of 88. And but you can, of course, appreciate that this is only one study with no external validation. So the question is always, what can we do with these models? But it's definitely well, promising for us to continue. But what's also maybe not so promising is that if they look only at the EEG features, then they see in their models that the sensitivity is actually quite low. And yeah, so that's the case for acute strokes and TIAs, but also the case for large vessel occlusions. So this is something that we hope that with our setup, where we specifically place the electrodes above the regions of interest for these large vessel occlusions, that we get better performance. But we'll have to see and wait until we get all this data. I will quickly go over this. So these are the inclusion criteria. You can also read it in all the settings. So we quickly go to the hardware. So this is actually what we now have in the ambulance. So we have portable suitcases. We have an Ego Mini amplifier, 2 dry electrode cap, 2 sizes, a tablet, battery pack, and also a cellular 4G connection. So we can continuously upload this patient data to our research center. And this is important because privacy is a big issue. We ask these patients informed consent afterwards. So we don't administrate any personal details during the study. We only connect the data, the EEG data, to the patient afterwards, after they provided informed consent, or if their family provided informed consent. And so the data stays on these tablets for a really, really short period. So these are the electrodes again. And what we did now is we trained 80 plus paramedics and drivers in 2 ambulance posts. And from December onwards, we have over 10 equipped ambulances that are actually driving around in North Holland. So it's one of the provinces of the Netherlands that are actually performing measurements in patients if they think it's a suspected stroke patient. So we are now in this, we will build up to this diagnostic pilot study on the right side in 3 phases. So the first phase was just basic research inside the clinical neurophysiology department, where we just compare wet electrode and dry electrode EEG, just to see how the dry electrodes work. Then we went to the neurology ward, where we actually measure in the patients with stroke, but after they're treated, so the non-acute setting. And then when we were convinced that our software and hardware all worked well together and did not introduce a lot of delay for the patients, we went to the emergency department. Initially, we planned to do much less patients here, but we recently updated this number to 250 as a maximum, because we want to continue measuring data on the emergency department, because so little patients have an LVO that more data is better. And currently we have over 100 patients measured. And for the final phase, so this year in the COVID period, we started in the ambulance. So you can imagine that at the start, the inclusion rate was quite slow, but we now have over 10% of this data available, of these 222 patients, where we actually measured with EEG, dry electrode EEG, by the paramedics in the ambulance. So before I can show results, we first need more data. And if I would show preliminary results, that would also hamper the publication options for us as well. And we also want to analyze our data after it's all collected. So I'm not showing any results yet, but I can say something about signal quality. So we get different artifacts that we already noticed. We get movement artifacts on the left. Sometimes you get muscle activity on electrodes because people are quite tensed, of course, and you get these muscle artifacts. Sometimes we also got bad electrode skin contact. For example, if the cap was not put on well enough, you can see that you sometimes also get artifacts or thread lines. So this is difficult because you can also get these signal changes due to stroke. So this is something that we're really working on to improve every day by additional training. And also we noticed that the hair type, so people with a lot of hair, it just tends to fit less well these dry electrodes. So, and you don't have any visible access to the electrodes because the cap is on there. So that's difficult. And also because of the time constraints for this ambulance, we decided to don't enforce the impedance check. But now that we saw the first data from the emergency department, we also decided to include an impedance check with a time limit, so that we always measure impedances and that we know that the impedance is not correct, in contrast to not measuring it at all. So the lessons learned, well, what we learned definitely is that dry electrode is less robust than wet electrode, but it's way faster to use. So for our use case, it's very good. And we also saw that that the trained personnel and experienced personnel was really good at getting good dry electrode data, and that people that did it for the first time, they definitely get well, less signal quality from this dry electrode EEG. And I think it's the same with wet electrode EEG. But it also emphasized that the adequate training of paramedics is of paramount importance, and it should be included. Even if we rule this out in more posts, ambulance posts, then we really need to focus on this training of paramedics. And what we also saw is that the signal quality now is sufficient in about 80% of the data, and it used to be less at the start of the study, but it improves as we improve the software and the instructions to the paramedics. So I would like to emphasize finally that it's a diagnostic pilot study. So it will give a first real-life insight on how dry electrode EEG can be used. But we definitely need to perform more research. We expect to finish the inclusions in 2021, so the 222 inclusions, because we now have over 10 ambulances driving around. And we also hope to start in 2021 with a new prospective study where we measure even more patients in more ambulance posts to also enable data-driven decision algorithms for decision-making inside the ambulance. And we just need more data for that than those 222 patients. And then in the third step, we also need to set up a large randomized controlled trial to actually validate then the algorithms that we developed there to get to the end goal, and that is that all stroke patients directly get to the right hospital. So with that, I would like to conclude. I would like to thank the core team on the bottom left, and also the collaborators from the paramedics of Ambulance Amsterdam and Witte Kruis, and also the collaborators in all the surrounding hospitals, and of course our partners and sponsors. So if there are any questions, feel free to ask them now.